Hi everybody, I'm Phil Pollock, Programme Manager of the Prostate Cancer Supportive Care Programme. I'd like to thank you all for coming along to the session this evening. And I would like to introduce Dr. Mira who's a radiation oncologist from the BC Cancer Agency in Vancouver, to talk to you this evening about prostate cancer brachytherapy. Dr. Keys.
Thank you. Good evening to everybody. So thank you for having me over here. So what I'm going to talk to you tonight about is a little bit about prostate cancer screening and then about brachytherapy for prostate cancer, and pretty much kind of put it into a patient guide. So I am one of the radiation oncologists. I work at a cancer clinic and I treat patients with prostate cancer and breast cancer. So I have been at this work for over 20 years. So lots of experience, lots of insights into how science changes over the years and decades and how things shift left and right and into the full circle. So, and this is why a story about PSA screening is actually completely fascinating to me, because I've kind of come to full circle. I became a resident when we just started to do the PSA, and it was a story of, wow, PSA is actually very, very important. It tells us how cancer is doing, to now through PSA screening, and now actually discouraging PSA screening, which is fascinating. So there's a few things you need to know about prostate cancer. First of all, it's extremely common, and occult cancer, which really means that cancer that just sits in the prostate, doesn't do anything, it's never going to do anything, but can be found if somebody is going to take out a prostate and look under the microscope. It's actually very common. And about 20 to 40% of the men in their 50s actually have it. So every second man in their 50s actually has some prostate cancer. And about 80% of people who are 90 years old have it. So very, very common. But most of these are never going to cause any problems, any issues, never going to be diagnosed. We just know about those because if people die, for example, in car accidents or something, and then they have an autopsy, then when they examine the prostate, whoa, there's a lot of prostate cancer. That's how we actually figure that one out. However, so you see how common this is, and out of all of these men, only 10 to 15% of all men will actually die from prostate cancer, and 85% of the men who have prostate cancer will actually die from something else. So that just gives you the scope. There's like two really extremes here. And this is really the cancer that needs no treatment, and some of you may have heard that. Well, we don't need to treat your cancer, we'll just watch you. This could be actually chronic disease where we don't really have a cure, but we have to manage it. Similar to diabetes, I tell my patients, just similar to diabetes, we have to manage it. It also could be a life-threatening disease. It could be very fast and very aggressive. So again, the whole spectrum, right? And also is a public health concern. And I'm sure some of you, you're here because you're concerned about the whole issue. And the public is certainly concerned, and the government, and we are. And also, it's a very profitable industry. And when I say profitable industry, I mean for the United States, for example. A lot of people actually make a lot of money out of treating prostate cancer. And this is not by distributing the best of treatment, but a treatment that actually makes a lot of money. And one of the examples are proton centers in the United States. We really don't need protons to treat prostate cancer effectively. However, proton treatment is probably the most expensive radiation or any other option for prostate cancer. So people cash a lot of money by treating the prostate cancer. So it's a lot of things. So we're just going to go to these objectives. We're going to talk about a little bit of diagnosis of prostate cancer, how we diagnose the disease, screening, and then something that you need to know, which is a risk stratification, which really explains why are some patients on one end of the spectrum and why are the other patients on the other spectrum of cancer, and how does that happen, how we figure out which patient is where. We'll talk about outcomes of these therapies and a little bit about prostate brachytherapy, and then also how to make a decision if somebody has prostate cancer. So I'll just start with the PSA screening, or a little bit about PSA in the background. This is really a protein that is made by prostate tissue only. No other tissue in the body actually makes that particular protein, so that's why it's really prostate specific, right? And so there is 10 times more of these protein being made in the cancer of the prostate rather than in normal tissue. So that's why somebody has cancer, there's blood test, PSA goes up, but also can go up if somebody has an infection or BPH, which is benign enlargement of the prostate. It happens in men who are aging, or trauma or ejaculation. And PSA is also used for screening to detect early prostate cancer or to detect cancer. And also could be used, and we use it all the time, to monitor cancer after the treatment. So a lot of different aspects to it. And so this graph is just to show you that you see blue on controls, and then to the left here are really cases. So there's a huge overlap in between these controls and cases. So PSA is not an ideal screening test by any means, and that's why there's a lot of confusion about what this all means. So 20% of the patients or men who have normal PSA, which is less than 4 nanograms per milliliter, actually have cancer. And 20 to 30% of the patients who have this kind of PSA in between, not here, not there, a little bit elevated between 4 and 10, actually have cancer. If the PSA is over 20, then most of the men actually do have cancer. Not all of them either. So lots of overlap, as you can see. So PSA screening, and I'm sure that most of you have heard that, we don't want to screen now for prostate cancer, and we really wanted to screen everybody, and then you see probably different ads all over the newspaper, depends on who is talking. So there is actually a massive confusion about the whole issue, and it has been controversial for many years, and I'm not going to tell you that only patients are confused, but I'm going to be very honest, a lot of physicians are confused, including urologists or radiation oncologists, and including, physicians who, for example, examine all the data and who now told us that this is how the PSA is going to be used for screening or not. So it's really a data that is there, but people have their own take on this data, their own perceptions and views, and this is where the difference actually comes from. So try to kind of just put some sense out of all of this to understand and kind of try to explain where this controversy comes from. So the purpose of any screening for cancer is really to reduce cancer mortality. And what does that mean? You want to reduce the number of people who die from that disease. That's really what it means in plain English. And so with PSA screening, you kind of damn if you do, you damn if you don't. So that's really the stage. And really with any screening, the benefits of that screening should really outweigh potential harms. And what are the harms of screening? Really include morbidity from investigations. If somebody has false positive results, for example, or anxiety, there's also harm of overdiagnosis and especially of overtreatment. So if somebody has cancer that's not particularly aggressive, you could watch, and yet the patient actually feels like, oh, I need treatment. So there could be a lot of side effects, probably unnecessary side effects, and so it's a very complicated issue. So there is really 2 studies that have been done and published some time ago in 2011, as you can see in 2009. One was done in Europe and one was done in the United States. And the study in Europe was actually very, very thorough. And this European study shows that there's 20% mortality reduction. So 20% mortality reduction, what does that actually mean? So if this is the mortality reduction here, then 20% less is here, if that's the whole scale, right? It's kind of really bit vague. It's a little bit vague. You think 20%, that sounds really a lot, but it's actually quite vague what it means unless you actually see the curve. So the part of that European trial was a Göteborg trial in Sweden, and it has a very, very long follow-up. And that trial actually showed that only 200, so close to 300 men need to be screened, and then you diagnose 12 in order to prevent 1 death from prostate cancer. That's very similar to mammography. And so nobody is going to dispute the value of mammography in breast cancer screening, but it's the same for prostate cancer. So where is the problem? And then the US trial really showed no reduction in mortality. So whether you get screened or not, it kind of doesn't really matter. But then really what they found is if you really look at a healthy man, they do have significant reduction, 50% now, reduction in prostate cancer mortality. And then more recently, they have gone back and looked at this US trial again, and they found that actually all the men in this trial, 90% of them actually had PSA. And some men had more frequent PSA versus less frequent PSA. So it's really not a trial of PSA screening, but it's a trial of more versus less frequent PSA. So it's really a trial that means nothing, really means nothing. So that's where all confusion comes from, and yet these two studies were used for, by the US and Canadian Preventative Service Task Force, which is a group of physicians that do not necessarily treat prostate cancer. And they unbiasedly are supposed to review all the evidence and then, make a recommendation. So they are policy makers and creators, and they said, no, we should not be doing PSA screening. So what does it mean, PSA screening? It means every man in British Columbia at certain age should have a PSA, every man. So we pretty much all agree that that's probably not correct, but so I'll just give you a little bit of answers to how that probably could be in the future. So, so how can we look at this? These are the screening facts. That PSA is very common. We know that already by now. That only 15% of, prostate cancer is very common, and only 50% of men will actually die from prostate cancer. Okay, and we know that PSA somewhat actually reduces the dying from prostate cancer. And really, the goal with this PSA screening is only to find aggressive cancer. And most cancers that will be found in the PSA screening will not be aggressive and may not need any treatment whatsoever. So many men will actually experience pressure to have treatment if the cancer is found, or they may have perception, oh my God, I have cancer, but I have it treated. So if you sometimes tell a man, you don't need any treatment, they still want treatment because this is cancer and they want to have their cancer cured or treated or whatever. So there's internal pressure, external pressure from the family, from the, their own reading or whatnot. So once the cancer is diagnosed, the question is, what do we do now? And so then there was a decision, and the PSA may be good for men that are willing to accept treatment only if they have aggressive cancer. And so this is how we would like family doctors to present PSA screening to their patients who are coming to the offices. So only if you're really willing to accept treatment if you have aggressive cancer, you should be screened. If not, then maybe you should not be screened, because there is a potential for lots of harm, and harm comes from side effects, really, of all the treatment. So what can help? Okay, so this is actually a brilliant study that was published in 2007. And so they have taken some 50,000 men in Scandinavia, and they wanted to really investigate the risk factors for cardiovascular disease. And so they took the blood test and stored the blood test in a basement and did their own testing. And then some 30 years later, they figured, oh, we have these blood tests, and now we have follow-up for 30 years on all of these men. So let's take a look who has prostate cancer and what was their PSA when they were 50. That was very, very brilliant. And so what they found, if the PSA at the age of 50 or less is actually less than 0.7, then the lifetime chance of prostate cancer is actually less than 10%. But at that young age, if the PSA is already around 1 or above 1, then the chance of prostate cancer lifetime is probably somewhere about anywhere between 60-70%, depends on how long into the future you look at. So huge difference. So that's something that we now call really a smart screening. So you can have this baseline PSA test on all the men who are age 45 to 50 and determine, are they really at high risk of developing prostate cancer or not? And if they're not, maybe you can do PSA once every 5 years, but if they are, maybe you need to actually pay a closer attention, to that PSA. So we're just beginning to understand really how to work that out. And so on that graph, this is really the PSA and their age, right? And so if the PSA is less than probability of prostate cancer, right? So this is the PSA. So if the PSA here is less than 0.75, they just cross over to this line saying the probability is about maybe 12%. But look at these men in their 50s, early 50s, who have PSA 1.25 or let's say 1.5. look at this curve goes significantly up. This is really very, very significant, right? And this is the lifetime risk goes up to over 80%. So that's called the SMART screening. And I think this is something that we need to kind of work it out. So this is probability of cancer and the total PSA. If it's more than 3 and you're age 50, then 60%, I would say this is actually probably higher number. Okay, so how do we make diagnosis? So prostate gland is really a little tiny gland that sits here in the base of the pelvis. And here is the penis comes out, testicles, and this is the rectum over here in the anal area. And here's the pubic bone in front, the bladder on the top. 90% of men who are diagnosed with prostate cancer have no symptoms whatsoever. They may have elevated PSA. On rectal exams, sometimes the prostate may feel as normal, sometimes it may feel abnormal, and the diagnosis is made only on biopsy. So we have to take some tissue. And so then how do we determine how high risk this prostate cancer is in somebody? So risk means like risk of any adverse events, risk of dying, risk of having cancer spread around the body. So low risk is the one that is going to behave really in a indolent fashion or not do much, kind of sit there in the prostate, don't do much, don't spread. But the aggressive ones actually can spread around the body, cause a lot of damage and symptoms. So we look at a PSA, we look at a T stage, and this is really come out from the physical examination, and then we look at Gleason score, which we get from the biopsy. So here's a prostate cancer right here, invading probably into the seminal vesicles that sit kind of at the back of the prostate. And so then the pathologist, right, and so Gleason score. So this is how cancer may look under the microscope. So it's a pattern that looks many different patterns. And so the pathologists have grouped these patterns, and this particular pattern they call 1, this is 2, this is 3, 4, 5. The 5 is super aggressive cancer. The 1 is really non-aggressive cancer, or this is now considered not even a cancer anymore. So really the cancers today are considered 3, maybe yes, maybe no, but 4 and 5 are really serious cancers. So they look at, usually this is a mixture of different patterns under the microscope. So they take 2 most predominant patterns and they say, well, this cancer contains Gleason grade 3 plus 4, which would mean that there's a lot of this type of cancer and there's a little bit of this. If that pattern was 4 plus 3, that would mean the predominant pattern is 4, this one here, and there's a little bit of that one. So that's really what it means a Gleason score. So, and so here is we call it risk groups, based on this blood test, T stage, and how prostate feels on exam and Gleason score. And there is a low risk group. You don't need to memorize any of this for sure, but just to give you an idea, this is the low risk group, then some kind of intermediate risk group, and then high. So we just kind of distribute patients into these groups because it helps us determine which treatment would be most appropriate for those. So what about then treatment? So there's different options, and there's curative options, and then there's non-curative options. So for curative options, there's surgery, and then there's a whole bunch of radiation options. One of them is external beam radiation. And then there's brachytherapy, or combination of these two. And sometimes we add hormone therapy into the mix. And there's also active surveillance, which is really not a curative option, but is an option to consider for the patients who have very low risk prostate cancer. So active surveillance, and I'll have a slide about active surveillance, but so we'll just put it over there for a moment and come back to it. And there's also some non-curative treatment options, which is radiation again, can be given to, let's say, painful bony metastases, or to prostate itself, just to shrink it and keep it under control. Hormone therapy alone, chemotherapy, or radium-223, which is a new systemic treatment. So active surveillance, so we're just coming back to that whole issue, does not mean no treatment. It really just means we're going to postpone the treatment. And we need to follow the patients very closely. And what it means, we're just going to watch the PSA, and sometimes we send the patients again for the biopsy, and make sure that the cancer really is quiet and it's not doing anything, in which case we can just watch the patient. So The issue with that is about half of the patients will have some treatment for their prostate cancer in about 5 to 10 years after they have been diagnosed. So half will avoid treatment completely, but half actually will not. So advantages of this approach is really that, as I just said, treatment may never be needed in 50% of the patients, which is great. And there's no treatment-related side effects, which is again great. And disadvantages, there's some uncertainty about this approach because we are a little bit looking at the tossing the coin to guess who is going to be in this 50% who will need some treatment. And sometimes both physicians and the patients can be actually quite anxious about that. And so somebody's going to lose a nerve and say, well, that's enough, now I have my treatment. So, and sometimes I tell the patients there may be a missed opportunity for cure as well, because if the cancer progresses and advances to a point where now we need more treatment and we're less certain that the cancer will be cured, then that also has to come into the mix when we discuss, the options for treatment. However, majority of these low-risk patients really, they need no immediate treatment. If somebody's 55 or 60 years old, I think there is some advantage if we can just postpone the treatment for 5 years and have this man have a good quality of life, and then maybe, trigger the treatment when the cancer starts progressing. So that is the whole philosophy beyond this active surveillance, and we practice it actually a lot. We used to treat low-risk patients, we don't anymore. So if we are going to treat somebody, so what are the options for treatment? So for low-risk prostate cancer patients, usually, as I said, we don't treat those men anymore, but surveillance is the best option, really. And however, sometimes we can advise prostatectomy for various reasons, or brachytherapy, so they're very good options. The chance of cure is very high, but the question is the cure necessary? So for intermediate risk patients, we do have brachytherapy or prostatectomy, sometimes external beam with or without hormones. And some men who have intermediate risk prostate cancer patients, we just watch them, particularly those who have a lot of other medical issues, heart disease, and they're not that well, they're older. They're probably okay without any treatment whatsoever, and that's actually quite safe. And then for high-risk patients, so these are men who have more aggressive cancer, the good options are external beam with or without brachytherapy, with or without hormones. And then prostatectomy, which usually then includes, again, hormones and external beam radiation after prostatectomy, or hormones alone. And sometimes we also now bring chemotherapy into the mix. And these are some average results in PSA control at 5 years in prostate cancer death and 10 years for all of these treatments. For the low risk, PSA control is about 90%, death only 1%. PSA control for intermediate risk is about 70%, death is now 7%, so more men die from this cancer. And for high risk, PSA control is about 50% and about 20% of men die from this cancer. It's also important to realize here that even though we treat patients, and many patients here, we don't actually make them live longer. So the treatment really prevents spread of the cancer and need for more hormones or chemotherapy. So we, in a way, by treating the cancer, we're trying to prevent the quality of life and sparing them these very toxic treatments with hormones or chemotherapy. So these are some, again, PSA control with 5 years with different treatment modalities. So brachytherapy is very, very, very effective in treating this cancer. The question is, do we need to treat that cancer? Do we need to achieve this? External beam is also pretty good. Surgery is also very good. So they're kind of comparable. Intermediate risk, again, so here are some numbers. And for high risk numbers are low, and this is a treatment that was really first tested here at the BC Cancer Agency. Now it's become the standard of care throughout the world from our results. And as you can see, the cure rates with this treatment alone is actually about 80%, which is very, very high. This is a publication that is very easy to understand and put together by a lot of international experts, very comprehensive, and we review literature that was available to us. I'm not going to go into great details, but I'm just going to show you this. A lot, over 50,000 patients are actually included in this review. And this is how results are displayed, where each dot represents a particular study. The number beside it is actually the number in the reference of the article. And then this is the follow-up. It starts at 4 years, so we were really looking at the very long-term follow-up. And this is the percentage of the patients who have this PSA control. So if you look at in this study, green is external beam radiation, red is surgery, and the blue is brachytherapy, so low-risk patients. And we're looking at the long-term PSA control. So everything seems to be very similar at 5 years, but really where difference are at very long-term follow-up, a 10-year follow-up, very big difference between, you know, the brachytherapy, the red prostatectomy circles, one here, and then the external beam radiation. So the circles around this is really statistical circles, which take into account the number of patients in each study. So visually, if I tell you this is results from external beam, these are results from surgery, and these are results from brachytherapy, and this is the number of years in follow-up, it's very easy to comprehend this very complex and complicated data. So, and this is 10-year PSA, again, PSA control for surgery, prostate brachytherapy, or for external beam radiation. So for intermediate risk patients, so those who have a little bit more aggressive disease, again, the same circles. This is all brachytherapy. This is a particular form of brachytherapy, surgery, external beam radiation. And for high-risk disease, again, brachytherapy. So this blue circle here is for the studies that use brachytherapy, external beam, and hormones. So it's called a triple therapy. It's a very aggressive treatment, but the results are really across the board very successful. So this is 10 and 15 years with a high-risk prostate cancer. So this is really the result that is very good. That's the only thing I can say. And this has been proven by the study done at the BC Cancer Agency, and that has really, study has changed the treatment of prostate cancer across the board in the United States and in Canada. Just in very general terms, brachy means short in Greek. So brachytherapy means that it's a treatment where we put radioactive sources directly into the tissue or directly into the cancer. So it's a very, very effective treatment for cancer. And we can treat cancer of the cervix, esophagus, lungs, skin, and many different types of cancer, including prostate cancer. It always works beautifully. You cannot always use it because of the, you know, how tissue is arranged in the body, but when we can, it works really beautifully. So this is a picture of the Paris at the beginning of the century. So really, the brachytherapy of the prostate started in 1909 in Paris, which is fascinating, when they were putting radium capsules through urethra into the prostate, and then went to New York, Memorial Sloan Kettering, and they were involved into putting radium needles into the prostate gland. And then in 1983, Dr. Holmes, he was a Swedish guy who introduced ultrasound into this procedure, so we can actually see where the prostate is, and we can see where, you know, we want to put the radioactive material. And he started to put little needles loaded up with radioactive iodine seeds into the prostate, and that's really how this modern era of brachytherapy has actually started in 1983. It went then to Seattle, and people from Seattle has really perfected the whole technique, and this is exactly what we do today across the street. There's two major forms of brachytherapy. One is called the LDR, or seeds or permanent implant, and the other one is called a temporary implant, or HDR technique, and it's available in Kelowna but not here. So who is the brachytherapy for? Could be used alone for low and some intermediate risk prostate cancer patients, or with external beam. Usually we like to see prostates less than 60 grams for those men who have good urinary function, and in some cases it's actually patient's choice. They can have kind of any treatment they like. The program that we have in BC is one of the largest in the world. There's I was at 20 oncologists, probably more like 25 oncologists now. A very, very large staff. We started in 1998, so almost 20 years ago now. There's actually more than 6,000 patients now. I always have to update my slide. And we keep kind of a track record of all the patients that we implanted. And that's really what makes this program fantastic, because I can tell you how the patients are doing based on the patients that we have treated, because we tracked them for 15, 20 years. So we know how they're doing. We have a lot of publication, research grants, and whatnot, and really participation in international societies. And we also do treat the patients from Saskatchewan because they don't have a program there, so they fly over here for the implants. And so this is PSA control. And as you can see here, this is very, very long follow. This is 5 years, 10 years. PSA control. This is how many men die from prostate cancer in red. And the green one is called overall survival. And these are the men who died from any causes, which is really most likely cardiovascular deaths, actually. Okay, so for intermediate and high risk, I was mentioning this trial that was done in BC. And so this is the arm treated with brachytherapy and external beam, and this is the one treated with external beam. So brachytherapy, when combined with external beam, gives far, far better results. And again, these are 10-year follow-up data. So this is being really extremely influential trial, just published, and you know, very, very, very significant. So the patients who have brachytherapy also have more side effects. So there's always a price to be paid. So yes, cure rates are really very high, but there's more side effects because treatment is intensified. There's more stricture or the scar tissue around the urethra in this group of patients. Now somebody can say, well, is that a fair price to pay? Well, it depends. Do you want to be in the group of patients that is cured or not? For some patients, this is very important. For some patients, this may not be important. And why is that not important? Because if somebody's 75, it may be more important to actually have good quality of life than to have a cure of prostate cancer. And then the prostate cancer becomes a chronic disease where we just manage it. But they're still doing well. They have good quality of life. So not everybody needs to be cured for prostate cancer. That's a very important point to kind of take home. And so it is an excellent treatment, but I always say it's a good treatment for healthy younger men and those who have good urinary function. It's not for every patient. This is what happens when we put a seeds into the prostate. So these are the pubic bones, urinary bladder, and so these are the little tiny seeds that we put in. So it's really a procedure that takes about 45 minutes in the operating room, and then patients go home. So total time when they come to see us in the morning until they leave is about 3 hours. That's it. So this is how it's done. So the patient is in this position with the legs up in the operating room. The ultrasound probe is in the rectum, so we can see the prostate on the ultrasound images. This is the catheter inside the urinary bladder, and there's a template in front of the perineum with needles that actually go through that template, and then they deposit little tiny seeds into the prostate directly. And so this is how big is the seed. This is somebody's finger. So it's a very, very tiny seed. And so this is one of the ultrasound images. So that's what we see in the OR, and these little white dots. The black is prostate. This is the probe in the rectum, and the little white things are actually dots, are seeds. Each needle has three-dimensional positioning within the prostate. So these are two coordinates, X and Y, and then there's a depth of needle. Not all the needles go to the same depth, and that's a Z coordinate. So it's like a little bit playing the chess with yourself when you're in the OR. So everything is very, very precise. And so I'll just show you some other images, so maybe it kind of is going to make a little bit more sense. Yeah, so we usually see patients then in 6 weeks, and then every 6 months to 1 to 2 years, and then maybe year 5, 7, 10, and then they're discharged. So this is basically an ultrasound. The whole procedure starts with consultation with radiation oncologist and then the ultrasound. So we acquire the images, so take the pictures of the prostate, and then we kind of contour or outline for the computer, say this is the prostate, okay? And then we also want to treat, we call it the margin or the tissue area that is just around the prostate, because the prostate likes to kind of creep outside of the prostate as well. So you can find some prostate cancer cells around here, and that is really actually very important to treat. And that's why surgery is not always successful, because the cancer cells are kind of left here behind, particularly close in this area, closer to the bottom of the prostate, as the surgeons are trying to really spare the sphincter that make men continent. So by trying to spare as much tissue as they can here, then sometimes the cancer cells are not removed. And if they would just remove more tissue, it would be maybe good for cancer, but then older men would be incontinent. So it's really a very fine balance between trying to remove everything and yet leave enough tissue inside so it's functional. The difference is that we can really treat this tissue around the prostate with with greater ease than the surgeons can, because we're not removing anything and they have to remove the tissue. And that causes incontinence removal, a lot of tissue around. So, and then, see, there is a grid now that we placed onto the prostate, and so these are all the blue seeds. And this is the dose distribution, where the green is the dose that we want to deliver to the prostate. And then this is a very high dose of the high dose in orange here with a big hole in the middle. And that hole in the middle is created in a way to preserve the urethra. Urethra is a little bit more sensitive to the radiation and contains no cancer. So we spare a little tissue around the urethra. This is still a very high dose around, but we just kind of shape it the way that we want it. And as you see, the margins actually get treatment, which is really why this treatment works very well. And then we go into the operating room, and so here is one of the therapists preparing the patient. This is how the seeds come loaded into the boxes. This is lead here to shield us from exposure to radiation. This is one seed. I'm sorry, the needle with the seeds inside and loaded. And so we do have the template in between that corresponds to that template that you have seen just on the images. So everything has to fit. We do a lot of measurements because we can only deposit needle once. Once the seeds are inside, we can't move them, we can't do anything, that's it. So you have to be very careful how we do this procedure. It's very operator dependent, just like surgery. You have to have a very good training to do this and do it a lot in order to be very, very good, just like surgery. And at the end of the procedure, this is what is left over. So this is the skin in between the scrotum and the anus. So these are little mosquito bites, that's it. Nothing else. Patients go home. So the same day, we also do a CAT scan. And so the CAT scan is for us to see if the seeds are in the correct position. And so here's again one prostate outline, and this green is the dose distribution around the prostate. This is the urethra, so we pretty much got what we wanted. So this looks like a very good implant. This is also done for quality assurance and for the training purposes, so people really kind of learn how to do this procedure very effectively. So the number of seeds depend on the radiation dose, which we can vary, and then the prostate size. Half-life of the seeds is about 60 days. So in about a year, 85% of radiation is gone. In about 2 years, 100% of radiation is gone. So why should men consider brachytherapy? You see, because patients go home. It took 3 hours. Bladder catheter is removed the same day, and very, very quick recovery. If patient wants to go to work the next day, no problem. They can if they want to. Excellent cure rates. There is minimal or no incontinence actually of the urine, so that's again a big difference with surgery. And it really has a very good preservation of the sexual function. So for young men, this is very attractive. The downside, there's always a downside in life. Downside is really urinary symptoms. And so 50% of the men have kind of moderate urinary symptoms. The worst symptoms are about 3 to 4 weeks after procedure. By 12 months, it resolves in 90% of the patients, but approximately 10% of the patients continually have some symptoms. And less than 5% need any Foley catheter because the prostate is too kind of swollen, so they can't really pass water. And about less than 2% need any surgical intervention later on in the few years. So they do actually very, very well. Some patients may have a bit of irritation of the rectum for about 1 to 2 years. Less than 5% have a little bit of bleeding. And the most feared complication of brachytherapy is really something that is called the rectal ulcer or fistula. And so this is really an ulcer that is inside the rectum. It would not heal, and people have to have major surgical intervention. So who gets these rectal ulcers and fistulas are men who have vigorous biopsies of the rectum. And so we really discourage those because we find that patients who have any kind of surgical intervention in that area are more likely to get a fistula. They're extremely rare. 1 in 500 men may get them. And if somebody is going to have surgery, just to contrast them, there is 1 in 500 chance that somebody may die on the table. So that's exactly the same as kind of surgical worst nightmare complication, which is somebody dies during the procedure. Sexual side effects. So overall, 50% of chance of somebody not being able to have erections after the procedure. However, so that's all comers. who does better, younger men, and those who have better sexual function before treatment. It kind of makes sense, right? And then sexual function also is related to aging, as you know. So we find that in some of our studies, I'm not going to go into great detail about this, but half of this decrease of the sexual function over, let's say 5 to 10 years is really related to brachytherapy, but 50% of that decline is actually related to just simply men being older, simply aging. So, and this is from our own patients, from our own database. Age less than 55, 5 years down the road, how many men are still sexually active? Of those who were sexually active when they came to see us, 80%. If you're about 60 to 64, then that goes down to about 50, 58 at 5 years and 53 at 7 years. If you're over 70 years old, 75 years old, and you come to see us for brachytherapy procedure and you're sexually active, before that, the chance that you will still be sexually active in 5 years from brachytherapy is only about 13 to 18%, because the men also age. And this is a little bit complicated graph. The bottom line is really that 0.5% of this decline is related to procedure, and the treatment 0.5% is related to simply aging. So what is good about brachytherapy is it has a very quick recovery, quick return to work, no incontinence, good sexual function, and excellent results. What's not so good is that urinary symptoms can drag on, and can be a little bit unpredictable, so we can never be 100% sure. And it really takes years to know if treatment was successful. So if you have surgery, for example, then we can look at the pathology, and if the surgeon has removed everything and the PSA is undetectable, so less than 0.2, then it's most likely the cancer is cured. Not 100%, we can never be 100% sure, but most likely it is. So you can know in about a month after surgery whether the cancer has been cured. With brachytherapy, we have to watch the PSA. It slowly declines over the years and sometimes kind of goes up and down. But what we have found is 3 to 4 years after the brachytherapy, if the PSA is less than 0.4, then the cancer is most likely cured again, 99%. And so how can somebody make a decision what to do? Well, the urologists are very helpful. They're surgeons. They will give you all the information you need about surgery. We also like to see all the patients and give you information about radiation options, and sometimes that causes a lot of confusion, and so patients are not sure what to do. But I think it's good always to have information that you need to make a decision. Family doctors can be very, very helpful to kind of put all of that together. Other healthcare professionals, and then lectures like this can be also helpful in providing information so you can learn more and therefore make better decisions for yourself. And then friends, spouses, books, internet, they all mean well, but they don't have the cancer, and if the patient have the cancer himself, then he's the best one to make decisions for himself. And there is a wonderful, wonderful website that was actually put together by Queen's University, and so here's the link. And this is really about making a decision how to treat the prostate cancer and what would be the best for each individual. And so they do have just diagnose, choose a treatment. So frequently asked questions. They've done a lot of research and talked to a lot of men to figure out what is it actually that men want to know. How do they make a decision? What will help them make a decision? So it's a very friendly, user-friendly website, and you're welcome to use that. So decision help at queenuniversitycancercare.com. Very, very, very good website. So I can highly recommend that. So I think this is probably all I wanted to talk to you today, and you do have a couple of minutes to ask me some questions. Thank you.